Good morning, good evening, welcome everyone. My name is Sarah Naster, and I'm the coordinator for the Interagency Working Group on Reproductive Health in Crisis, or IAWG. For those who aren't familiar with IAWG, we're a global coalition of organizations and individuals, and for 30 years now, we've worked collectively to advance sexual and reproductive health and rights in humanitarian settings. In brief, we accomplish this through coordinated advocacy to policymakers, funders, and implementers, through research and the mobilization of data, and through different types of technical assistance and support to frontline implementers. As some of you may know, in December, IAWG started an exciting partnership with CanWaCH, the Canadian Partnership for Women and Children's Health. CanWaCH is now the organizational host for IAWG, which is really exciting. For those joining from the IAWG side who may not be familiar with CanWaCH yet, the Canadian Partnership for Women and Children's Health is a coalition of over 100 Canadian-based organizations dedicated to advancing the health and rights of women, children, and other marginalized populations around the world. CanWaCH is driven by the power of meaningful partnerships, fostering collaboration to strengthen global health outcomes through data-driven decision-making, policy engagement, and cross-sectoral initiatives. So I'm very pleased to welcome you all to the first of what I'm sure will be many joint IAWG CanWaCH events. Among other things, our partnership is meant to create stronger programming by bringing awareness and access to best practices, tools, and research from our respective sectors, provide new learning and collaboration opportunities, and create greater cohesion across the sectors. And the topic that we're all here for today is something that's very relevant across all of our areas of work and is really a perfect example of what we are hoping to accomplish with this partnership, among other things. So with the housekeeping taken care of, thank you, Deborah. I think I am ready to pass it off to our presenter, Alice Castillo from Clear Global, one of IAWG's newest members. We are so grateful for your willingness to share your expertise with us here today and how it applies to the work of our respective coalitions. We look forward to your presentation, and we'll have some discussion and questions at the end, which will be great. So with that, I'll hand it to you. Thank you all so much for being here.
Thank you so much. And thank you very much for the warm introduction. We're really excited to be here. So I'm Alice, and I'm joined by my colleague Maria, and we're going to spend a bit of time kind of talking to you around language issues. We come from an organisation called Clear Global, but you might have heard of us by our previous name, which was Translators Without Borders. We did a rebranding a few years ago to reflect our kind of wider work on research and advocacy. You may well have already heard of us under that previous name. So let's move forward. Good, it did it. Right, so we're going to spend a bit of time today looking at what are the major issues around language in health programming. And we're going to take a look at that, looking through the lens of language data, at communication relay, and at direct communication. And I promise you, we're going to try and give you solutions and recognise very, very much that all of us are in difficult financial situations at the moment in our organisations. So we're going to also try and make sure that we've got solutions for different budgets. Let's put it like that. So let's start a little bit with the kind of the basics. So speaking a marginalised language and not being able to communicate in an official or a major language is a contributor to vulnerability. And the people who are most likely to be in this position are people from marginalised language communities who had the least chance to go to school and to learn the official language, or maybe people who also had limited access to public spaces where they might have been able to learn that language. So typically, that's women and older people and people with disabilities. People who speak marginalised languages have difficulty across many sectors of information. So they get less access to health-based information, but also progress less well through the education systems. They have less access to representation opportunities and less access to technology. And across all of the world, we know that poverty translates to low literacy, and that includes less access to the languages of wealth and power. So that means that people who speak marginalised languages can be some of the people you are absolutely the most keen to get hold of and to communicate with, but also some of the most challenging people to reach. Across all of our research, what we find is that a lack of understanding of language and communication barriers is compounding women's vulnerability in particular. So language just isn't a gender neutral issue. We know that across the world, women get fewer educational opportunities, so they lack both the language skills to operate in an official language and the opportunity to be literate. In every context where we've researched, we find that pictorial content and audio content in local languages is critical for successful communication with women. And what we need to make sure is that that is also there, those lessons are also drawn into digital programming. So for effective health programming, we need to give people the information that they need, but we also need to be able to hear from people about their needs and their concerns and their issues. In general, health topics are hard to discuss, particularly the more sensitive topics around reproductive health. And so the words that we all choose, we choose with great care to try and avoid shame or to make an explanation less embarrassing. But if we can't hear that from people who speak another language to us, we're likely to miss that really important nuance in the language. So we need to make sure that language is properly built into our assessments so that we can hear from people who speak marginalized languages, into the health information that we provide so that we can make people feel safe and comfortable with the information we're giving them, but also make sure they fully understand it. And also in our health referral system so that we make sure that when we offer people a service, they're going to be able to access it. So I'm going to break some of those pieces down. And it all starts with having language data. And this is one of those problems where it should have been solved years ago. And it's a real surprise that we're still struggling with understanding who speaks what language and where. We know that organizations choose the language for their programming based on the best information they can find, which often is talking to local organizations and key informants. But the research that we've done in many countries now shows that this consistently underestimates the local language complexity. And in fact, it can even reinforce existing patterns of exclusion. But in all of the issues that I'm going to cover in this presentation, gathering language data and sharing it is probably one of the easiest things to do and one of the cheapest things to do. So a few years ago, we worked with REACH and we got included in the multi-sector needs assessment the key question, what language do you use at home? And that showed us some really interesting things, which I'm going to dig into a little bit more now. It showed that affected populations are often much more linguistically diverse than humanitarians and development organizations assume them to be. And when we looked at it, we found that humanitarian organizations often neglect the languages that are spoken by a very significant part of the population. So on this slide from Mozambique, you can see just how important local language information is and what an important factor literacy is to communicate with women. It also showed that marginalized language speakers were facing real barriers to getting access to assistance that they needed. For example, you can see in Somalia that the largest group of responders who reported being denied aid were speakers of the May dialect of Somali. And once we discovered that, we went on to do further work in Somalia, which actually revealed significant language-based exclusion from humanitarian action. The MSNA, the Multi-Sector Needs Assessment, also showed that language marginalization correlated with being less satisfied with aid. And that suggests that we need to find ways to be accountable to speakers of marginalized languages. We might want to be able to use language use data to do ongoing monitoring so that we can find out who we might not be hearing from or who might not be accessing the health services we're providing. And by using that data, we should be able to start breaking it down and addressing those gaps for them. So here comes the first of the solutions. We have begun this process and we would love to be able to collaborate with you to do more of this. We have been resourced over the last year or so to create a space where the global humanitarian and development community can share language data. And I've put the link at the bottom, and it'll go out in the pack as well. So we have now hundreds of thousands of people who look at our maps every year. And the current map, the view that you're looking at now, shows you the single biggest language in each of the administrative districts. In this case, I've chosen Zambia as an example. That's one way of looking at it, and it gives somebody who's programming nationally a sense of what the dominant languages are. Our platform also allows you to look at how a particular language is distributed across the country. So you can think about the resources that you're trying to create in a certain language and what kind of reach you might be able to achieve with that language choice. And I think that's a very important thing in terms of making decisions about resources. The last view that you can get for the language data is a chart. And I know everyone loves a map, but in some ways these charts are even more useful, because what this allows you to do is to look at a particular district in the country that you're working in. So this is Kambopo district, and to look there at the language breakdown of that area. That means that when you're doing an assessment in that area, for example, you can be very specific about choosing which languages you might want to work into. You can also use it when you're choosing which partners you might want to collaborate with, to make sure you're choosing partners who speak these appropriate languages. And certainly you would want to use this district level data to monitor your services and adjust your communication strategy to make sure it's speaking to all of the population groups, and to make sure to understand if there's any of the language communities who are not accessing your service. So I think this level of data is really now an incredibly useful level of data for ongoing monitoring. We've now mapped 30 countries, and we're going to map another 30 with existing funding. But if all of us include some key questions in our routine assessments, every time we do an assessment, we collect these key questions, and we share it with each other. And you're welcome to share it directly with us so that we can put it on these publicly available maps. Then it means we can all benefit from each other's data sets. This is really a no-cost exercise, which gets you some really important insights about who you might be trying to reach. And I've highlighted there what we think are the best 4 questions to ask. But if you can only get in one, just ask that one in orange and get that one into all your assessments, and you will be a long way forwards in understanding the language and profile of the communities you're working with, and in particular the languages you might be wanting to use to reach women. I'm going to pass over to Maria now, who's going to talk through the next stage of issues around language relay.
Thank you, Alice. So moving on from the data, let's now look at some communication challenges. Our research over the years has identified key issues that local partners and staff encounter, both when working with international partners and when applying global guidance, such as guidance in health and education in local communities. So let's dive into this area a little bit more. Next, please. Organizations often assume that working through local partners or with volunteers or even hiring local staff is going to be enough to manage language barriers. But in multilingual contexts or where there are displaced communities, local and partner staff may not understand all the language needs in that community. So what happens is that most national and international NGOs will prioritize recruiting staff who have both technical skills and an ability to speak to them. So essentially the people who can speak an official or colonial language. This means that the recruited staff are likely to be some of the most educated people in the context and less likely to be from marginalized language groups. They may not be aware of language exclusion happening, but coming from the same country does not necessarily mean having a shared language. And of course, unless the organization has data on which languages affected people speak and understand, they won't in any case know which languages to recruit for. So our research tells us that humanitarian partners and local staff and volunteers are also struggling to bridge the language gap. We need to support and resource them if we're going to expect them to fulfill their roles. The first part of that is to make sure we communicate clearly with them. Next, please. The challenges listed here are likely not new to you, but partners often face barriers like meetings without interpretation or funding applications only being accepted in official languages. But something I wanted to highlight that our multi-country study found is that our efforts to engage with partners are actually also hampered by our inability to create accessible guidance. Service provision often relies on healthcare workers to relay complex information, but the local level staff struggle with global and national guidance, and they can face two types of barriers to this.
So,
okay, I'll keep on going. Barriers to physical information. And that can be limited reading time, expensive costs to access online information, unreliable electricity supply, and even just being confused or overwhelmed with what kind of information is even out there. And then when practitioners can get hold of relevant information, they're still struggling to meaningfully engage with it. Guidance is generally not available in the languages they're comfortable reading. It often uses unfamiliar terms and acronyms, is too long and too dense to navigate. It is very often in PDF formats, so people can't get to the part that they want and they can't navigate easily on their phones, which is how many access documents. And guidance often also isn't localized to their context, and then it feels irrelevant. And when people on the ground can't access or understand key information, then risk communication and mitigation strategies start to break down. Next, please. A focus group participant from Mozambique expressed very beautifully what accessible guidance should look like. Do summaries, include boxes with key actions highlighted with bright colors, put in bullet points. Here you have many action points and ideas in a paragraph. People do not have time, electricity, or other conditions to read long sentences. People are in emergency. So what can we do to improve communication relay? Next, please. Firstly, the first thing we can do is we can provide accessible guidance for partners. We really can communicate clearly for the widest possible comprehension, but we need to make the effort to make it happen. And we need to build it already into the contracts of those who write for us. Creating our tools and guidance documents in plain language rather than complex language has absolutely no cost, but has a very huge impact. So where money is tight, this is yet another area which you can still make progress without funds. Plain language is a recognized discipline of writing, which helps the reader understand information as quickly, easily, completely as possible. It favors familiar terms and simple sentence structures, summaries to aid recall. And plain language helps us all, but it particularly helps people who may be reading in their second language. And it is also likely to lead to a better quality translation where you actually have resources to translate as well. At Clear Global, we do not believe in having a complex version and a plain language version. We believe that all documents should be created using plain language principles from the outset. And we can provide plain language editing and training and how to write in plain language. So feel free to reach out to us at Clear Global if you think it would be useful in any of responses that you're working in. Secondly, we can communicate in the languages of our audience. And that includes using the appropriate variant of the language used locally. For instance, Congolese, not Kenyan or Tanzanian Swahili for DRC, and Mozambican, not Brazilian Portuguese for Mozambique. If you cannot afford to translate the whole document, then again, at least translating key concepts and definitions is already a big help. To help with physical access to guidance, it is good to vary dissemination strategies. Ideally, you would want to budget for widespread dissemination of durable hard copies, also considering dividing longer documents into separately printed modules so that they are easier to share and carry. Also, developing audio or any audiovisual versions can further expand access to the content. But where budgets are tight, identify the most relevant content. Give people a one-line summary of what the content is so they can decide whether to download it. And really respect the use of their limited reading time and download costs. And you can do that by emailing materials directly and then signposting topics and categories of content like urgent, practical guidance, background reading, reference, etc. Next, please. The other key part of supporting the relay of information, is supporting the interpreters and translators that you and your partners work with. This includes enumerators, volunteers, community health workers, really anyone who might be having to relay information, carry out assessments, discuss health, or explain how to make complaints. As we mentioned before, talking about sexual and reproductive health is an area where we need to use words which make our meaning clear while making people feel safe and respected. Our terminology testing research looks at how people use and understand words in their language. And we have run this testing in many countries and languages, including the Democratic Republic of Congo, Iraq, Haiti, Venezuela, Bangladesh, among others. Next, please. So firstly, let's remember that our sector is full of jargon, and it's a major cause of confusion. And our comprehension testing in Northeast Nigeria showed that even the trained enumerators struggle with acronyms like WASH, SAM, and terms like wasting, accountability, or consent. So we often expect translators, interpreters, and partners to transfer these complex terms quickly and smoothly, but the terms themselves are often a challenge, and they're also very often unclear. So we really need to spend time with interpreters and translators to help them understand the concepts we want to discuss, and to work with team members to discuss concepts that maybe we already know in advance are going to be hard to explain. And in that way, at least we are giving them some time to think through how they can explain a concept. And proper terminology support really is essential. So let's dig a little bit deeper in that. Next, please. So we all know that the more embarrassing or shameful a thing is, the more obliquely we talk about it. And we also talk about things differently with different people. So if I talk about my menstrual cycle with a doctor, I might say menstrual cycle. But with my friend, I'll talk about my period. And with children, I might use different words again. And our research shows that, firstly, older and younger people or different genders may use different terms. And we have multiple examples for this. Sexual assault in Rohingya will by women be referred to as stain or dishonor, but men would term it as torture. And terminology for adolescents evolves very rapidly in many contexts, and it needs regular checking. As you'd imagine, historical or cultural connotations can also influence how people interpret terms. So in Haiti, for example, we found that people linked the term exploitation in Haitian Creole to ideas about economics and colonialism. You might also need to accept that some concepts don't have a non-stigmatizing term. So you might end up choosing between least bad options or between a good term and comprehension. For instance, in Rohingya, there were terms for men who have sex with men, and those would be either men who do an evil deed or men who use a substitute. Neither of those are good, but you should at least choose from a perspective of understanding. And finally, as I mentioned in the previous slide, technical terms and abstract terms are a real challenge for staff and volunteers to understand and to translate. And in those situations, explanatory phrases that use simpler words are likely to help you communicate effectively. Sorry, just need a drink of water. So, for example, in Malawi, the translation of negative, oh gosh, sorry. The translation of negative coping mechanism was not well understood. Instead, people found dealing with, oh Lord, I need a one second for water. I should have been saving my voice before the presentation. Yeah, so I was saying that in Malawi, the translation of negative coping mechanism was not well understood. And instead, people found dealing with a problem in a way that creates more problem much clearer. So it can often be better to accept like a short explanatory phrase rather than really searching for a one-term solution, which will likely result in less comprehension. Next, please. And interpreting is a really challenging role. And many people doing this in low resource languages aren't professional, but just strong bilingual speakers. But we can make their job so much easier if we just invest in resources to help them express key concepts. Clearly, we need to review our own language very carefully, eliminating jargon and technical terms where possible, explaining concepts as clearly as possible, and then working with colleagues to discuss what concepts are the hardest to convey, and investing time with communities to understand the terms that they use to express that idea. And that can enable you to create a glossary. You will need to listen and talk to both men and women, both older and younger, as language really isn't used in the same way by everyone. And at Clear Global, we have publicly available multilingual glossaries, including hundreds of health-related terms in multiple languages. We have humanitarian glossaries in over 60 languages with plain language definitions. And we have done deep dive guidance notes for many languages looking at specific issues and sensitive terminology. And if we work across agencies, then the glossaries can become a shared resource. And we would really be happy to guide you and your partners in the key steps to developing glossaries. So again, please do reach out to us if you think that would be useful. And I will hand over back to Alice because my voice is not carrying it anymore long.
Fabulous. Sorry, I'm unmuting. Yes, I'm unmuted. Wonderful. Thank you, Maria, and good luck with getting rid of the frog in your throat. Okay, so Maria has talked us through some of the challenges that our partners, enumerators and translators face in relaying information. But there's also a lot of information that we create directly in our programming, which is aimed specifically at communicating directly with the community. And I'm going to spend a couple of slides looking at some of those things. So we know, and we have found through our research also, that visual information is really critical. And I'm sure all of you are using pictorial information in your programming in different ways. And this still needs to be a key part of how communication takes place. But we've also done a lot of communication testing around pictorial information. And we found that there can be a lot of misunderstanding around pictorial information. So I'm going to just take a few slides to look at that. Oh, it's not going to move forward. Come on. Yes, now it is. So we've tested pictorial communication in lots of different places. And in lots of places, the message is just not clear. The message that was intended is just not clear. And these are some of the common challenges. Often there are just too many messages put on one poster. And I realize this is often a funding issue, that you're trying to get as much key information into one resource as possible, but actually it leads to increased confusion and lack of clarity. Symbols like arrows and ticks and crosses are often meaningless and confusing for the communities who are seeing the posters. And we cannot assume that those basic symbols are recognized by everybody. In some places where we tested it, for example, arrows were not understood at all, but a pointing finger was understood to give direction or sequence. The problem is that we assume that those symbols work everywhere, and they don't. Also, colours carry symbolism, which sometimes has both religious or political connotations, and our assumptions around, red meaning stop and green meaning go, for example, are not consistently recognised. So I'm afraid there isn't really a low-cost solution to this, but we need to be doing testing. The other key issue is that some images reinforce messages that you may not be trying to get across. So this poster, for example, was part of a portfolio of posters around humanitarians, saying that humanitarians should not be exchanging favours or money for sex. And when we tested this in DRC, what it was seen as is that there was a woman seducing him, and it reinforced the stigma and the shame that women were already experiencing who were in relationships with humanitarians, often as a survival strategy. So in fact, instead of encouraging the reporting of it, it meant they felt further stigmatized and were less likely to report. So I'm afraid while glossary is a relatively low-cost exercise, which is what Maria was talking about, pictorial work, there really isn't a particularly cheap alternative. What absolutely is a priority, though, is to either co-develop the pictorial information or at least test it, and to test it again with a number of different audiences. We're sort of working our way up the cost effort as we go through this presentation. So the next area I'm going to look at is digital channels. And obviously there's a huge amount now of digital health programming being developed. And the digital formats are often used, for example, also to support hotlines or in things like chat-based communications for people who might be trying to raise concerns or to find information. And I'm going to very, very briefly touch on the challenges. So we did a big study about a year and a half ago with GSMA, which is kind of like the global mobile phone sort of consortium. And what we looked at is digital humanitarian practices. And two key findings came out. At present, digital information isn't in the right languages for marginalized language speakers. And then the second issue is that because it was all text-based, it limited the engagement for anybody who had low literacy. The research was absolutely clear in its finding that what we needed was digital solutions that included audio content and voice-based ability to be able to be used so that people could get the information they needed and they could be heard using voice and images alone. And our research did show that lots of people who had very low literacy still used their phones. They had been shown how to send a photograph to their sister, how to leave a WhatsApp voice message. So it wasn't that they weren't using digital formats, but they were using them without being able to use the text functions. And we need to keep that in mind as digital health gets designed. But current language technology really isn't helping, or it's not helping quickly enough, I think it's fair to say. So the language models that are available don't prioritize the relevant variants. So for example, language technology is quite widely available in Portuguese, but that's generally geared to European and Brazilian Portuguese, and it works much less well for Angolan and Mozambican Portuguese, for example. And the computers just can't hear the words spoken in the languages with the dialect from those countries. In many contexts also, people are mixing languages. So they're using a digital service in their second language or contact language. So if you think of Kinyamulenge speaker refugees from DRC who are based in Kenya, they're probably using health apps in Swahili, and they're mixing in the two languages. And while humans are very good at understanding that, language models, which are trained exclusively on standard variants, just cannot recognize when languages are being mixed. And finally, as I was saying before, that while people who have low literacy and low tech skills do still use digital tools, generally the technology is developed assuming a high level of digital skill. And in the aid sector, many intended users are just less familiar with technology, and it needs to be, the interfaces need to be much more straightforward. So again, we do have solutions. I'm not going to go into the full technical detail here, but I'm happy to take questions on it. I always dread saying that because then somebody asks a hard tech question, but I will be able to take questions on it to some extent. But we know that the key to making good digital communication in the health sector is to be able to get audio content and text to speech and speech to text models in low resource languages. So we are using our huge community of linguists. We have about 120,000 linguists to start building voice technology. It's not a cheap solution. We have now developed, we've had resources now to develop a platform which makes it much cheaper than it was before, and which means that we need much less data than we previously needed. So we'd love to be able to talk to you about it. And if you have a use case where you think that getting audio and text to speech available for your digital tool would help, please come and talk to us. But it still does remain on the higher end of the cost spectrum of solutions. But of course, what it can do is mean that all the huge effort that you put into creating a digital tool means that it can suddenly get a reach far beyond what it may be able to do if you're only using a text functionality. So we're coming to the end of the presentation, and I'm just going to really try and sum up what the key issues are. So the first part is making sure that we are aware that for years, the humanitarian and development programming has been looking and counting around other forms of vulnerability, making sure it was doing gender disaggregation, making sure it was looking at people with disabilities and disaggregating there. And those are vitally important. But language has been the long neglected area of exclusion in both humanitarian and development programming, and we need to become aware of it, to ask who speaks what language in the areas where we're working, and what language assumptions are we working. We also need to make sure that we then do something about it, and that's building it into the full program cycle, making sure our assessments are language inclusive, making sure we're supporting our communicators, the enumerators, the translators, the interpreters, and our partners, so that they can confidently relay our messages. And that's about us getting better at being clear and concise in our material, but also about giving them resources such as glossaries. And sharing language data. And then we need to make sure that we are consistently disaggregating, finding out who is missing, which language communities made no reports on complaints to us, for example. Are we actually hearing complaints from across all of the language communities who use our services? Are our referral services giving people access to identifying services where somebody can use their own language to reach that service? And who doesn't go that far? Which language group in the communities we're serving is not having the uptake that you would expect them to have? And by doing this, we'll begin to start gathering the data about which are the language communities that are most excluded. And ultimately, that will mean that you can then focus the limited resources that you have, and we all know how tight those resources are, onto the languages of the communities who are the most excluded from your programming. So it means that you can start using that information to be really precise and thoughtful about how you address language and address communication. So we can help with lots of things. We've shown you some of our practical resources, the language maps, our glossaries, the questions that we've got. We've got a whole load of online guides. We've got online translator training and interpreter training. We can do tailor-made training. But we'd love to collaborate with you, and crucially, to share some of those bits of data that you might be able to find, whether that's around the right terminology which you would just like to make sure you can share with all of your partners working in that field, or whether it's around particular insights into how a certain group is going to communicate, or whether it's a deep dive into communication preferences or just language data. All of those things are areas where we'd love to help. So I'm going to stop talking and thank you all very much for listening. And I'm really excited to still have time, and I'm glad that we do, because I was worried we might go on too long. But I'm really happy to take questions. So that means I'm going to try and stop sharing and get to a stage where I can see everybody. Yes.
We haven't had any questions in the chat box yet, but
okay.
Please add them, or take the floor.
Absolutely. So now in that case, if we haven't had questions in the chat, please do stick your hand up and feel free to ask any questions that are interesting. Was it too daunting? Somebody's asked about marginalized languages. Okay. Fantastic. Okay. Okay, so exactly what does it mean? Thank you very much. That's a great question. So I think when we think about marginalized language speakers, we tend to imagine, the smallest community in a remote area. But actually what we're talking about often is a very large language community. So for example, let's take Pakistan, because that's an excellent case study in marginalized languages. The official languages in Pakistan are Urdu and English, which are the two largest languages and which are used for most health information, but also used for example, for things like emergency warnings. But actually, Urdu is only spoken by about 10% of the population as their primary language. So if you didn't go to school, you're not likely to have learned Urdu. The largest language community by far is Punjabi, but there's some 30 million Saraiki speakers. So that would be considered a marginalized language in the context of Pakistan, although from a purely numerical perspective, 30 million speakers is huge. Or you could look at a language like Hausa, for example, which is sort of spoken in Nigeria and Niger and the various countries around it. It's got 60 million speakers, but because it's split across multiple countries, it actually is the official language in very few countries. So it becomes a marginalized language because it's not the official language spoken, but actually work that you might do in Hausa is going to benefit some 60 million speakers. So we don't have to always imagine the smallest, most remote community with a few thousand speakers. We should be thinking also about marginalized languages of including some very large languages. I can see somebody is trying to raise your hand, somebody called Cassie. Feel free if you've got a question. Okay, feel free to carry on trying or to put your question. You're putting your question there. Okay. You're wondering about translation of medical product names and trademark products. Have we had insights in that? I'm not sure we have. We've done lots of work with how to take products. So where we were working with, for example, in the Rohingya community, that we did a lot of work with organizations who were distributing medicines and needed to give the instructions about how to take it in local language to people who couldn't read. And in fact, the Rohingya language has no written form anyway. So it's an entirely oral communication. So there we worked with them on pictorial information to try and help people understand when they should take their medications, for example. And I have to say, pictorially, getting the distinction between sunrise and sunset is an interesting challenge. But we have done, and we've done work around that, but I haven't worked on brand product names. In general, I would suggest you don't translate them, but you may want to put them in the appropriate script. That would be my guess. Usually the product itself will have some guidance about how it gets translated. Thank you for the question. It's a good one and a hard one. So well done for catching me out pretty much first on. Okay. Megan's asked whether we'll be expanding to include marginalized Canadian languages. I think we already do. That doesn't mean we have them all. So we work in about 300 languages. And we may well have some of the Canadian marginalised languages as part of that portfolio. And in fact, I know that we work with a number of partners who already do so. So we'd be happy to connect you if that's a need that you have. But having said that we work in 300 languages, it sounds great, but there are 7,000 in the world. So it's still, I'm afraid, a drop in the ocean. Tam has asked about sexual reproductive health technology-based tools that are doing a good job. So there's a few, there's a lot of people who are doing some great work. People like Jacaranda Health, for example, and Viamo are doing some really, really interesting work in this area. And there has just been a sort of white paper published by Stanford University and a couple of others, which has laid out a couple of examples of some really interesting practice. So there are people doing it. We also developed with a couple of partners, for example, a multilingual chatbot during the COVID period to answer people's questions around COVID questions. And what was interesting from that is, although it was designed for a certain area of northeast Nigeria, where communities lived together but spoke different languages, the questions coming from different language communities were very different, because the information that they had and the misinformation that they had was also different. So it meant that you could get, for example, a certain community asking about, was garlic and ginger an effective cure for COVID, while another community was much more concerned around vaccinations, for example. And that's because those communities, although they cohabited, were getting very different information to access to information, and different information. Still picking up questions from the chat, but do feel free to raise your hands if you actually just want to shout out a question. So community organizations practically ensuring inclusive health programming. I think what we'd like to suggest is that you kind of work through the sequence of how you understand what the language barriers are. So the very first thing we would recommend, both to grassroots organizations and to larger organizations, is whenever you're out meeting people and doing assessments of any kind, you ask people what their primary language, what language they speak at home. And in that way, you'll begin to get a picture of what the language profile looks like. And that way you can start recruiting volunteers, for example, who speak those languages, or talking to your interpreters about what their challenge is in reaching that language. So even where there's no additional money to do it, it allows you better insights into where you need to reach to, which languages you need to reach to. And I would say that that's kind of point number one. You can then look at some of the plain language principles in the materials you design for communities and focus on audio. And audio is also human to human conversations. It doesn't have to be tech-based audio, but how you make sure you prepare the humans who you're working with to have that cross-language conversation, and making sure they have the resources like a basic glossary, which can be as simple as a spreadsheet. It doesn't have to be an online app with lots of functionality. So I would say start there, and supporting your interpreters and recruiting volunteers who speak the right languages is a really good start. Okay, I'm continuing to work my way down through the questions list. Elaborate on the main barriers in creating accessible communication. Why don't we do it more? So Randa, good question. Why aren't we better at creating accessible communication? I think we're a sector full of technocrats, and one of our challenges is that we tend to allow the final review of our materials to be done by technical specialists, and in many ways that's not really the very best people for communication. We tend to pay our communications teams to communicate clearly and effectively, and we pay our technocrats to be really good at being a doctor or having insights into pediatric needs, and we don't tend to cross-fertilize those two. So things like talking about, getting plain language into as a basis for all our communication is really neglected. And I would say that's one of the major barriers. If we could make what we say simpler and clearer, I think all of our ability to get that into other languages would be enormously helped as well. So I do think a lot of the challenge lies within our own ability as a sector to try and simplify, by which I don't mean simplify the content to be, to dumb down, but I just mean to say it as clearly as possible. And I think that's a really big thing. And is it mainly funding as the reason we don't? You know what? I think the fact that donors never ask for language disaggregation, and as a sector, we are never asked to say whether we are language inclusive in our practice, is a driver as to why this has been neglected. You would never do programming, health programming, and not do a gender disaggregation to find out whether you were getting an appropriate uptake from women. That would never happen, because the donors now have understood that that's an issue and drive that through their monitoring. The fact that it hasn't been driven through financial incentives and monitoring has been an issue. I'm carrying on going down. Have we had experience on conveying communications around SGBV and safe abortion care? Yes, a lot. And we continue to have those conversations, and we have done a lot of work on sexual violence, for example, around the SGBV. We've had a little bit less work around abortion care, but only because we haven't had people come to us. We would be delighted to do that, and we have done a lot of work on sexual violence and sexual abuse and how people talk about those issues. So we're very happy to carry on working in those sectors and around the abortion care terminology and how people want to talk about it. Okay, a question from Chelsea. Apologies while I read this. Says, curious how you manage politicized, marginalized terminology. Example, may give that in terms of men who have sex with men. Yeah. Yes. Okay, so how do we choose words without contributing to stigma? It's very, very hard. And we have had to make some very hard decisions as well. And we always make them with our partners. So we don't do anything alone. We work with partners to make sure they can effectively communicate. But for example, we worked with the collective UN family around their rules for around sexual conduct for humanitarians, their rules around preventing sexual abuse and exploitation. And in that, for example, we created a plain language version of their key humanitarian principles regarding sexual exploitation and abuse. And one of the things they talk about is commercial sex workers. And we did a lot of testing. And in almost everywhere we tested, people just didn't know what that was. They didn't know what a commercial sex worker was, but they did understand the word prostitute. So in the end, we had to take that question back to the UN groups and say, look, you can use this term and it's not stigmatizing, but it's also not understood. So if you want people to understand what you mean, you're going to have to, you're going to have to choose whether you want people to understand what you're talking about or whether you want to use a non-stigmatizing term. And it's a hard choice. And there was a lot of discussion. And in the end, they accepted the word prostitute. And then we had to be very careful that in further translations, that didn't become a more pejorative term. So if you're then passing that on to a translator, you need to say, find the best term, the least insulting term for this group of people, because otherwise we're going to be further stigmatizing them by translations which escalate a pejorative term. But there isn't a good solution in lots of these, and you have to decide again and again, do you want to be understood or do you want a non-stigmatizing term? And you might choose both in different materials, depending on who you're trying to talk to. And that's life. I'm afraid language is an imperfect science. But a very good question, and one that still causes us much grief a lot. So thank you for that. Then prescription order writing guidelines require non-proprietary name, e.g. not a trade name like paracetamol, and it can be used instead. Oh, it's e.g. paracetamol can be used instead of Panadol, Renadol, Canadol. Okay, Dr. Stephen, I'm going to say I don't have an answer for this around the prescription uses of names. You've raised something that's really interesting, and I don't know what the best answer is. And I suspect the best way of achieving it would be talking to the doctors, on the nurses and the other medical professionals where you work, to try and work out whether there is a generic name that gets you away from the brand names and encouraging its use. I'm sorry, I don't have a better solution on that one. Goodness, they're great, these questions. They're coming in thick and fast, and I can see we haven't done much longer, so I'm going to keep going through. Do you have any resources or recommendations for organised to better estimate costs associated with translation and equitable funding future? Very good question, Jessica. How to budget for this? I mean, you're very welcome to. I mean, I suppose a very straightforward way is to go out and get quotations for the actual translation of material. But in terms of training interpreters, building glossaries, we would be happy to work with you to give you some rough ideas for any particular context, I think is probably the best answer. So do get in touch. Doesn't mean you have to then take up whatever it is we offer, but we can probably give you some suggestions. At the very lowest cost end of the spectrum, when you have no money at all, it's sitting down with your local team, your local staff, and some community members, and making sure you buy everybody a snack and pay their childcare costs so that you can have that conversation and do it informally. And at the and that's your kind of your minimum cost effort. And then obviously it kind of increases depending on volumes of material and how much testing you want to do, and whether you're developing a digital solution. And how do we work with 300 languages? So we have a community of linguists who are volunteers who work with us. 120,000 volunteers at our last count. And we work with them because they volunteer their time. They are either professional linguists or very strong bilinguals in their community, and we pay them where we can for the work that can be paid, because we try and achieve that, particularly in low resource languages. And we provide them training in how to be an interpreter and how to be a translator, and we build up their skills, and they get a number of kind of additional benefits for working with us. And that's how we do it. And we tend to build up our language community based on humanitarian need. I can see that people are dropping off, and I can see our hosts are coming to the end of their time. Please do get in touch, and I'm very happy to carry on answering questions. Is there anything else, both Deborah and Sarah, is there anything else that you would like me to address before I go?
No, I don't think so. We can try to pull some of these remaining questions in and see, yeah, if there's a way we can sort of circulate answers afterward. But otherwise, yeah, I think we're good. Thank you all for the really great engagement and questions. This is obviously, as we were preparing for this, we were like, each of these things you're touching on could really be its own presentation. So potentially stay tuned for some follow-up webinars or trainings, resources. We're excited about partnering with Clear Global going forward. So yeah, thank you, Alice and Maria, so much for your time and your expertise. And yeah, huge thank you to CanWaCH and IAWG members for showing up and the great questions. And we will share the presentation and the recording, including the French translation, out afterwards. And please feel free to share it far and wide with your colleagues and partners. And yeah, thank you all so much for being here.
Thank you for inviting us. Thank you very much, everybody, and for fantastic questions.
Thank you.
Bye, everyone.